So, some of the things that have been very much on my mind since I started working as a facial reanimation surgeon and just as a facial reconstructive surgeon in general, were how to really understand the social and functional implications and not just the surgical aspects. When I think about managing patients with facial paralysis, for instance, I'm fairly confident that I can get patients back moving. I can get them to a place where their faces are typically fairly symmetric and that their face from paralysis. And those with synkinesis, I can try to do my best to help get them symmetry as well. But what I've suffered with and what I've struggled with is really trying to get patients to feel like they did prior to surgery. And I don't know why that is. And I think I've figured out part of the reason, which I'll explain to you guys today, and some of the research we're doing to try to figure out how to better prepare patients for what may happen and how we as physicians and support group members can help to counsel patients if they do develop facial paralysis or the side effects of facial nerve injury. So today we'll be reviewing social and functional implications of facial paralysis and dynamic procedures used for facial reanimation. But I'd really like to focus most of my time on the research that we're doing to better understand the patient's experience, especially the acoustic neuroma patient's experience after development of facial paralysis, and to provide data on how well your reconstructive surgeons assess those patients as well. And then I also want to discuss artificial intelligence and machine learning and how this technology is allowing us to really objectively assess patients and to really, when we have it in a place where it can be widely adapted, improve how we assess outcomes and potentially let us know which interventions may work for certain patients and which may not for others. And then I'll be showing you a program that we've recently developed. So when we talk about the face, we know that it's evolutionarily important for survival. It defines our individual identity. It provides verbal and nonverbal communication. And as far back as Charles Darwin and probably before that, we knew that emotional expression was universal and highly conserved amongst species. And those species that cannot communicate are ones that don't survive natural selection. And the functional deficits associated with facial paralysis are also numerous. So in the upper face, we focus on the brow being ptotic or depressed. So you can see on the left side, this person's brow is not able to lift the way it is on the right. This can cause visual field problems, inability to see out of certain portions of the eye. Obviously, blink is a very important issue. One of our support group members mentioned that they suffer from severe dry eye. This is known to be a big problem for facial paralysis. Even though they can make tears, the tears don't cover the whole eye because the blink is not working properly. Patients can develop exposure keratitis and potentially go blind if this is not managed appropriately. The middle of the face droops significantly, can cause problems with breathing on the left side. And then obviously in the lower face, not just when we talk about the smile and emotional conveyance, but also oral incompetence, difficulty eating, difficulties with speech, articulating, and also obviously providing emotion. So how do observers see the face? Well, this is a picture of my daughter. And so the areas that we primarily focus on when we see a person immediately is this central triangle. And as observers, data has shown that within the first 2 to 3 milliseconds, not seconds, but milliseconds, our eyes are drawn as observers to this area between the eyes, the nose, and the mouth. Now, when we look at research that was done at Johns Hopkins by Dr. Lisa Ishii and Patrick Byrne and Dr. Bohene, we found that when we look at how observers view patients or view people's faces, we find that we again follow the same metric. We focus directly on the center of the patient's face. And so what you notice here on the patient on the left, you see at their normal face and when they're smiling, the triangle is not skewed at all. The heat map signifies the red area shows where our eyes are focusing the most amount of our attention. It's directly on the eyes of the patient and then a little bit on the central of the mouth. Now, when you look at a person who has facial paralysis, that triangle is significantly skewed. And so that leads to confusion, that leads to hesitation, and that also leads to different judgments and things on the observer side, again, within that first 3 milliseconds. Now, these can be corrected with surgery, we found, but at the same time, this is one of the major impacts that patients with facial paralysis experience. Now, the psychological distress of facial paralysis is also fairly significant. Patients with facial paralysis have been found to have social isolation and depression in 65%, which is about 3 to 5 times the general population. Quality of life is significantly affected. Patients with facial paralysis have reported a dramatic impact on their quality of life. When looking at utility outcome scores, patients with facial paralysis rate themselves below people who are blind in one eye and on par with end-stage renal disease. And so we know that it significantly impacts your life. And again, this is one of the things I've struggled with, is how to take a patient who's going through significant emotional distress and to say, well, just doing surgery or is gonna change that. I know from my own experience with patients that surgery alone does not help the patient to go back to where they were before. And there's a long list of papers and data to support the fact that we as physicians need to do more to help improve the quality of life. And a large percentage of patients, about 20 to 30%, who are deemed cured by their physicians because they have subtle asymmetries after facial reanimation surgery, or maybe their synkinesis is not considered to be as severe as other patients, and they're deemed to be cured. We know that those patients still present with significant quality of life issues, and the data supports that we need to do more to help those patients. Now, here are examples of what facial paralysis looks like. It does not discriminate male or female, ethnicity, race, gender, age. They're all affected by patients by facial paralysis. But some of the things that I've tried to do in our research is really to find out what facial paralysis sounds like. And so we performed a study interviewing patients who had acoustic neuroma surgery and developed facial paralysis afterwards. And this is an excerpt from one of those interviews. This is a 43-year-old woman with acoustic neuroma and who developed facial paralysis after surgery. And so I used to look in the mirror and I would walk away depressed because I did not know the person I was looking at. I had looked at myself in the mirror for 40 years and I was okay with my imperfections. But as soon as I had facial paralysis, I couldn't look at myself in the mirror anymore. But these are pretty powerful words. And these are not often the words that patients will share with their doctors in the office, nor are they the words that doctors will ask about or the caregivers will ask about. So the purpose of the study was really to dig deep and find out how the facial paralysis affected patients and where along the line of management could we make improvements so that patients didn't feel so isolated and didn't feel so alone. So just a little background on acoustic neuroma, which obviously you're aware of. These are slow-growing tumors. They're benign tumors, also known as vestibular schwannoma. There's about 1 in 100,000 persons per year who develop them. Management options can be observation, microsurgical resection, or radiation, or all three at some point in the natural history of the disease. Injury to the facial nerve can result in paralysis with significant issues, not just functional, but social and psychological as well, with an estimated incidence of about 15 to 25% of patients. I don't know if this is reported by a lot of surgeons out there, but this is the data that's in the literature. As I mentioned previously, anxiety, depression, anger are commonly noted in patients with facial paralysis, but little is really documented how well patients are educated about the development of this or the coordination of care following surgery. So as I mentioned earlier, we did qualitative research or interview-focused research. And a lot of people wonder what this is. If you're not familiar with it, it's really research approaches that are used to understand complex everyday human experience in its natural settings. We do this with interviews and focus groups and surveys. We try to do this in a safe environment as possible, which may or may not be in the doctor's office and may not be the most comfortable setting. And so we try to do this where patients are most comfortable, where they can provide really the feedback that we want to hear. And obviously, all of this is anonymous once the interviews are completed. Qualitative research conforms to the notions that reality really is socially constructed, and we need to ask questions that we can't just simply ask during a 5 or 10-minute interview in the office. The research is important because this is the type of research that addresses the how and why questions to allow us to gain a deeper understanding that we can't always get with some of our more quantitative research, where we're looking specifically at millimeters of movement, and which is also important, but doesn't necessarily answer the same type of question as to how successful a procedure is. And so our objectives were really to learn about how acoustic neuroma patients' educational experience related to their facial paralysis as a sequela or as a side effect of treatment. And we wanted to focus on how facial paralysis really impacts the emotional health, the self-perception, and social interactions in our acoustic neuroma patients. And so we looked at several questionnaires: anxiety, depression, and then the face clinometric evaluation, which some of you may be familiar with from your doctor's office visits. And then we performed interviews with these patients. And so these are the types of questions we asked. In the background, we wanted to ask them if they were employed, retired, or if they were still in school. We asked about when the facial paralysis started, what treatments they had, what groups they most interacted with. We wanted to know what symptoms were most bothersome, if they could describe their symptoms, had they compared presently to when they first started. Some of these patients had facial paralysis for weeks and months. Some of them had them for over 10 years. We wanted to know which symptoms were most or least troublesome for them, how they manage them, and if their physicians. Sorry, was there a question? Oh, sorry. And if their physician offered to help in different aspects of this. We also wanted to find out how daily activities were affected, and then lastly, how self-perception was affected over time. And then finally, their treatment options. Which treatment options did they have? How well were they educated? And were they satisfied with the care they were receiving? So 4 major themes were identified. First and foremost, we found that there really was a lack of patient education about facial paralysis from the surgeons who were treating the acoustic neuroma, not from the reconstructive surgeons, but from the doctors that were scheduling patients for surgery. And as I mentioned, the data supports 15 to 25% of patients are developing facial paralysis. But in my experience, and this is very anecdotal, I believe that those numbers are not as highly mentioned to patients. And we also found that patients felt that there was a lack of appropriate care coordination after facial paralysis. And now this is not true for all patients. Obviously, our data was only 10 patients, but a lot of them really did say the same thing. We found that there were significant changes in physical and emotional health, as has already been described, and that there were often significant changes in the social interactions patients experienced. So here are some examples of what patients said in their own words regarding the lack of education. Here's one patient who said, on one hand, I was told I have to be patient. And I said, okay. So I went home and I was patient. It was 6 months later, it was 9 months later, and I still didn't understand. What does this mean, be patient? How long do I need to be patient before I start to see or before I start needing to do something? There wasn't much more communication. There was no discussion about synkinesis, one of the side effects. Theme 2, lack of care coordination. Can I say care coordination was almost non-existent? There were no resources, no support, nothing else. It was an area for me that really needs improvement. Never was I ever referred to any place or said there's an acoustic neuroma association or a facial paralysis Facebook page, nothing. I had to find that all on my own. Regarding physical and emotional issues, patients did describe the very common ocular dry eye, issues with eating, drooling, speech articulation, and then synkinesis. Regarding depression, some patients were very depressed, some were not. Again, one person did mention that they had no hope for recovery. And then another person was the quote I mentioned earlier. In terms of confidence and feeling self-conscious, patients did say that they felt less confident, that they were guarded, that they were reserved in who they were allowing into their life and who they wanted to experience social situations with. In social interactions, we found that friends and family really did, the bonds did get stronger, but it was more difficult being around strangers. It was somewhat difficult being around work. However, we found one area which really provided a lot of help was the virtual world. And so this is something that, again, with the Acoustic Neuroma Association and other social media platforms, patients were able to go and find help and find inspiration and to find and to get motivation and support from others. And so, again, we see it right here where we're presenting to the Acoustic Neuroma Association support group that this is a very safe and supportive environment. And so for patients with acoustic neuroma and facial paralysis following that, it's important to have these safe places. So our next question, though, now that we've discovered or we identified what patients were saying, we really wanted to see how well my colleagues were managing these different aspects of facial paralysis. And so we performed a similar study where we interviewed 10 facial plastic surgeons. And we wanted to find out what aspects of management were most important and to see if patients who manage facial paralysis really believe that they're managing the physical and mental health equally. This is just going into the methods that we performed. And so in this setting, we wanted to ask physicians when they were interested in facial paralysis, how long they've been practicing with facial paralysis, and who they often interacted with. We wanted to find out what their approach was, have they been using any new techniques or treatment options, if anything, what made things challenging to take care of patients, which symptoms were the least and most difficult, and if they had changed their treatment patterns based on their experience. We also wanted to know which part of the history and physical exam were most important, if this had changed over the course of treatment, Did they do things like taking photos and videos? And then did they also use questionnaires? And lastly, we wanted to focus on treatment and decision making. For the treatment aspects, we asked what procedures they performed, if they were satisfied with these procedures. And then from a decision making standpoint, we wanted to know if they felt that their patient was involved. Again, I mentioned previously that patients with acoustic neuroma had mentioned that they felt that they were not as informed from their acoustic neuroma surgeons. And we wanted to see if this still also similarly played out in terms of the reconstructive aspect. So from this, we found that 6 surgeons provided educational materials to their patients. 5 specifically asked questions about mental health. 6 offered referrals to mental health experts if needed. And 7 surgeons noted that mental health was more of a priority today than when they started practicing. And the average length of being in practice for these surgeons was about 7 years. 4 major themes were identified. We found that surgeons were interested in lifestyle changes related to facial paralysis, that they believed that they did have a grasp on the emotional experience of patients, that they were satisfied with their therapeutic options, but they were not entirely satisfied with the tools available to measure the outcomes. And so here are some quotes from actual surgeons. So when asked about lifestyle changes, surgeon number 1 said, "I'll ask what the most troublesome part of this situation is, what bothers them most, and then they'll find out how facial paralysis affects them, their daily life, and what they can do to help with their lifestyle," which is very different from what we were hearing patients note their acoustic neuroma surgeons were asking. In terms of understanding the emotional experience, this is just one example, but of the several quotes that we had. But the surgeon said, "I do believe my patients feel very self-conscious. They're aware of others looking at them. They're hyper-aware of their asymmetries. This can create social anxiety in social situations that lead to a more social withdrawal. Particularly, eating can be very difficult, and it's a very vulnerable time when they're out. If they have trouble with oral incontinence, facial paralysis creates social isolation, feelings of depression in my patients. With their therapeutic options, they feel that there's still areas for room to grow and improve, but they do feel that they're giving options, the best options to the patients." And when talking about tools and outcomes, one surgeon did display some frustration that we have lots of tools and outcomes to use, but it doesn't seem like one thing really is the most helpful, and that we are still using many different types to try to get our goal. And so the data from this study, these 2 studies, we believe that acoustic neuroma patients with facial paralysis do lack adequate counseling and preparation for life with facial paralysis from their providers. That after the injury to the facial nerve, providers, such as the acoustic neuroma surgeons, the neurologists, and the neurosurgeons, should consider the patient's goals, preferences, and values so that appropriate treatment decisions can be made. And that the reconstructive surgeons, while following a systematic algorithm to assess the physical symptoms, do not seem to follow the same algorithm for treatment of emotional aspects. Even though they do note that they exist, it doesn't seem that patients are all getting the emotional health or help that they need. So what are we going to do in the future? So these are small studies, but we're really trying to now go back a step and try to assess our acoustic neuroma colleagues or treating colleagues to see how well they perceive that they're preparing patients. And so we'll be doing a larger survey study of neurosurgeons and neurotologists to try to identify that. The goal would be to figure out where the gaps in communication are so that we can now develop new educational tools to bridge these gaps and improve that acoustic neuroma facial paralysis patient experience if patients do experience this outcome. So I mentioned before how we tried to find out what facial paralysis looks like and sounds like. And so the third portion, I'll briefly discuss some treatment options for dynamic reanimation, and then I'll go into a new tool based on artificial intelligence on how we can really assess these outcomes. And so there are a wide variety of options available. I'm not going to go into all of these, but many of you may be aware that for static procedures, specifically the eyebrow, we typically cannot get that to move again, especially if you have complete paralysis. So we can do brow lifting. For the eyelid, people are doing eyelid weights. I actually don't do them anymore. One of my colleagues, Dr. Hardkraus, does eyelid surgery and reconstruction, which we found to help for patients with facial paralysis. Many patients will also can undergo static slings. For the dynamic procedures that we focus on, nerve grafting, nerve transfers, regional muscle transfers, and free muscle transfer are things that I'll be reviewing. And then adjunctive procedures, muscle excision like DAO excision has become very common or popular now. Selective neurolysis has become more popular, and the chemodenervation, which is really just a big word for Botox, helping patients with synkinesis. And so these are some examples of patients. These are acoustic neuroma patients, this one in particular, who had facial paralysis for 1 year after a resection on the left side. And so for her, we did a temporalis tendon transfer. This was actually not a muscle, this was not a nerve transfer, but we took the temporalis tendon, and this was a procedure described by one of my mentors, Dr. Patrick Byrne, when he was at Johns Hopkins. He's now at Cleveland Clinic, in which we make a small incision in the crease where on the crease of her, on the left side, you can see we made that incision, and we attach the muscle to the corner of the mouth so that it helps when she bites down, she's able to smile. This is a gentleman who did not have acoustic neuroma, but he had a parotid resection of a salivary gland resection. His facial nerve was cut, and we anastomosed his masseter nerve. And this is a procedure that description from one of Dr. Bohenney's papers, in which we transfer the masseter nerve or the chewing nerve to the distal branches of the facial nerve so that when he bites down, he's able to give a nice smile. This is a young woman who was born with congenital facial paralysis, but similar to acoustic neuroma, she wasn't able to move the left side of her face. And by doing a gracilis muscle transfer, where we took tissue from the thigh, we were able to transplant it into her face with a nerve, artery, and vein, and we were able to help her generate a smile when she smiles on the other side by transferring the nervous input over to the other side of her face and the muscle, and also by biting down. Now, this is a young girl who did have acoustic neuroma, and she presented about a year after her paralysis. And so we did a dual innervation using the nerve from her tongue as well as the masseter nerve, the chewing nerve, to provide her with tone at rest and also with the ability to smile. This is a gentleman who had a cancer, had a tumor, in which he had a free flap transfer, but he also had the nerve transfers, and you can see that putting the nerves together, we're able to help them generate symmetry when they're smiling. Now, what I've shown you up to now are really what we would call still images of patients. And so, again, another area that I personally have struggled with is that I know I can take a patient and I can help them smile again, and I can help them generate a smile for a still photo. But one of the areas that I think we as surgeons have a lot of room to improve in is how patients look and function in the dynamic sense. And so while I showed you the before and afters of this patient, and I believe she has an incredibly beautiful smile, there are some limitations when she's speaking in general, when she's just talking to us. And so this video you can see here, this is 4 months after her surgery. She's just beginning to use her nerves, and everything's starting to work because it does take 3 to 4 months. But when she's speaking and talking, it is hard for her to generate movement on the right side when she's not really thinking about it. And so in a moment, you'll see her smile and you'll know that the nerve is working, but she does have a hard time when she's just talking to us. So here you're seeing her just do kind of the facial nerve exam. And there you go. You can see that she's able to generate that smile. Now, when we look at let me go back here. When we look at her at 2 years out, you can see her face at rest is much more symmetric, but she still has difficulty speaking using both sides of her mouth. And so, again, our goal as surgeons is to continue to improve our outcomes. And so this is an area that we're trying to figure out how to do that. Likewise, this gentleman is now 13 months from the surgery I showed you, and while he could generate a beautiful symmetric smile, when he's speaking, he's still primarily talking on the left side. And so many surgeons will show their still images before and afters of patients, and I do myself too. And so the images you see on the static images on the side look great. And I would say that those patients have excellent outcomes, but it only tells a part of the story. When you just take a small cut from the video, you can see that there is significant asymmetry here. And this is an area where we have a lot of room for improvement, I believe. And so one of the areas we as surgeons have difficulty in is reporting these outcomes. Because facial paralysis patients are a relatively small number, there's a lot of subjectivity, meaning that the graders who perform these grading systems have different opinions. And so myself, my colleagues may rate the images I showed you very differently. While I would say the static images only tell a part of the story. The long-term applicability of our current grading systems is really not known. And again, there's still significant differences between still and video reporting. And so what is the ideal tool? Well, this was something that was developed by the Sir Charles Bell Society, which you may or may not be aware of. This is a society of reconstructive surgeons, neurotologists, head neck surgeons, neurosurgeons, and it's an international body that focuses specifically on trying to help patients with facial paralysis. And so the group put together a position paper in 2015, trying to figure out what would be the best grading system or the best tool to use. And so they wanted it to be convenient. They wanted it to work on the entire face, but also focus on regions. They wanted it to work on both static and dynamic measures and include features to include synkinesis. It also had to have low inter-observer and inter-observer variability, meaning that it was not going to be subjective and that two people who looked at it would be able to have the same scoring system regardless of what their bias was. And it should also be able to follow changes over time. And so the society wrote that the ideal tool for evaluation will be objective, allow for easy communication between practitioners or healthcare providers, and should include information about emotional health. And so really, there's only one grading scale that satisfies the criteria, the Student Book grading system right now. But I would argue that it's very limited because it really only focuses on static images. And in 2022, we're really living in a dynamic world with the technology that we have. Let me scoot here. Or I'll go back here. And so, at this paper in 2015, they mentioned in their study that the grading scales were subject to limitation because of the degrees of subjectivity, reliability, and longitudinal applicability. But at the time, they said that the quantitative technology was not widely available and was expensive in 2015. Therefore, physicians at the time or clinicians really had to rely on some form of subjective methodology. Well, luckily in 2022, we have new technologies. The scale is much larger and the cost or barrier to entry is much lower. So for those of you who are not familiar with artificial intelligence, this is a field of computer science which can mimic human intelligence. And an example would be creating a robot, for instance, that's going to follow if and then statements. So if there's an object in the path of the robot and the question to that is true, the robot would stop. However, if the question was not true, there is no object and the robot could interpret that, the robot would continue along the path. Now, that's artificial intelligence. But machine learning is something different. It's a subfield of artificial intelligence, which then enables machines to use past data and new experiences without being programmed. And we can use algorithms or code to analyze data, learn from it, and make informed decisions. And the idea being that we can create a tool that can then perform automated tasks to improve classification systems. And the more data that we give to that tool, the better it will get. And examples of this in everyday life are internet security, malware trackers, weather forecasting, for instance, and then stock market security or robo investing. They all use some form of artificial intelligence. And in medicine, we use a lot of artificial intelligence. We use intelligence in the field of pathology to help diagnose certain diseases. We also use it in radiology as well for the same reason, and for testing blood and mucus and other body samples. We use it for developing new drugs. We use it to assess patient experience and patient safety. And we've also started using it in things like virtual reality-based surgical procedures. And so the question my group had was, can machine learning be applied to the evaluation of kinetic movement or movement in videos? And so these are some examples of videos taken from Mass Eye and Ear, where our group was able to overlay these little beads on the patient to assess movement. And this is a person with normal movement. And so most of these programs are obviously assessed on patients with normal facial function as they're much larger in the population. But this video on the right shows a patient with facial paralysis. And so the first study we did was just to see if this can work on patients with facial paralysis, because the asymmetry, the movements were different. Can the computer do it? And what we found was, yes, that can be done. And so our study wanted to assess, well, whether this system could use could assess no difference between quantifying facial asymmetry versus using clinical expert graded scales, specifically the ones I mentioned previously. And so this is just some example, a slide that we have about how the program works. And so what you can see is the videos were taken in, they were extracted from the system, and the computer model basically then overlays all of these dots on the patient, and then these are measured to see if they're tracking properly. And again, this is the machine learning aspect. So the artificial intelligence was placing the dots on the patient, but the machine learning from that is when we adapted to the patients with facial paralysis. And these are some of the measures we're focusing on specifically. Right now, we're looking at brow elevation, we're looking at oral commissure symmetry, like the corner of the mouth, and we're looking in the mid-face to see how well the cheeks elevate. Another area where I think we don't pay enough attention to as doctors, and then also how well the blink is going. And so these are the measures we looked at, just like we would in a normal examination that you might have in your facial surgeon's office: eyebrow elevation, gentle eye closure, tight closure, wrinkling your nose, pursing your lips, gentle smile, smiling with teeth, and speaking. And so this is an example of another patient. This is an example of our program in action on a patient with facial paralysis. And you can see it even tracks with the person's face as they're moving and rotating, which allows us to get even better measurements. And so this study that we published found that these facial landmarks would allow us to get quick, easy measurements of these patients for the measurements we were specifically looking at. Now, there are other measurements we need to introduce, but we're able to show a proof of principle. And I think this will actually help us really, really develop better ways of tracking patients and assessing outcomes. And so our future directions for this are to look at prognostic predictions of functional recovery. For instance, if a patient with facial paralysis comes in, rather than just seeing them and taking a video, the hope is that we can track them over time and see if certain patients have improvement in their functional recovery or movement, and potentially be able to put together some more studies to say to those patients coming in, like the patient you mentioned earlier, without having as much data, how well they'll be able to recover. We'll be able to at least provide them with some data and say, look, we've looked at 100 or 1,000 patients who were similarly paralyzed to you or recovering the same place where you were at the 2 or 3 month mark, and give them some more data that we can actually say, look, we think this is where you're going to end up in 6 months or 12 months, or we can say it might take longer, or it may allow us to say, hey, look, this is where you're going to end up in 12 months, and it may give us a better idea of if and when we should intervene. We want to be able to refine the evaluation of our outcomes. So after having surgery or after having chemodenervation or Botox or physical therapy, see if it's actually working as opposed to objectively or subjectively measuring it. And then again, in the decision-making process for surgery, if and when the right time is and what is the right procedure for specific patients. So I think this is very powerful data. We really now need to focus on spontaneous movement. We'd like to create a mobile platform so the patients can really assess themselves and make a way, which we haven't done yet, as I mentioned. We'd like to figure out how to incorporate quality of life measures, because really it's not just the objective or the measurement of the quantification, but really I think from the previous research I showed you, trying to improve the quality of life just as much as trying to improve the amount of movement for patients. I'd like to thank, these are my co-authors for this original project, Dr. Bose, Dr. Samantapelli, Dr. Narayanan, and then from the surgical side of things, Dr. Tai and Dr. Volker, who you may or may not be familiar with as one of our neurotologists. And I'd just like to leave with this. This is a quote from The Overstory by Richard Powers. I don't know if any of you had a chance to read it, but it came out in 2019. And it's one of the books that really changed my life in appreciating the world around us and a lot of the subtle things that we take for granted. And so one of the quotes from his book is, "There is no knowing for a fact. The only dependable things are humility and looking." And so as a reconstructive surgeon, I mentioned to you, I think we can get outstanding outcomes in certain areas, but I think we're having incredible lengths that we need to continue to cover in order to get outcomes improved from the dynamic movement in real life. And also, I think from the improving the way we handle the psychological and the emotional aspects of patients with facial paralysis. And so I'm happy to answer any questions or take any feedback that any of you have regarding some of this research. And thank you for your time. I greatly appreciate it.